Welcome, everybody. Welcome to Conversations in Interventional Cardiology. My name is Frank Ng. I am Chief and Co-Director of the Heart Center at UC Davis and Associate Editor for SCAI. I'm honored to represent SCAI and the Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jsky.org. JSCAI is the home of all the official SCAI documents. Now, we're here today to discuss a very important document that is published in JSCAI and is entitled Technical Recommendations for Computer Tomography Guidance for Interventions in the Right Ventricular Outflow Tract, Native RVOT Conduits and Bioprosthetic Valves. And I'm joined by an esteemed panel of SCAI leaders and experts in the field. Dr. Kelly Han is the first author of the paper. She's from Utah, the Intermountain Primary Children's Hospital in Salt Lake City. Dr. Matt Gillespie is the medical director of the cath lab at Children's Hospital of Philadelphia. And Dr. Shabana Shahanavaz is the director of the cath lab at the Heart Institute at Cincinnati Children's Hospital. So thank you very much for joining us. I'm going to turn this over to Dr. Han to start the conversations and include why this is an important paper. And I know Dr. Han has prepared some slides for us. So go ahead, Dr. Han.
So I want to thank you for the invitation to present this paper. And it's the first paper that I'd like to call sort of imaging for intervention. And I think it really highlights the important collaboration between cardiac imagers and proceduralists, which includes both surgeons and interventionalists. So for the background, pulmonary valve replacement is one of the most common interventions that we do in congenital heart disease. And when we look at sort of imaging for intervention, there's been tremendous progress in the use of non-invasive imaging to really plan aortic, mitral, and tricuspid interventions. But pulmonary valve really was kind of the valve that did not have any guidance for it. And so we got together a group of imagers, surgeon interventionalists that included pediatric and adult cardiology and radiology. And we really wanted to talk about what information can we give to both surgeons and interventionalists to help them plan their transcatheter or surgical valve replacements. And we really wanted to have a standardized approach to image acquisition, image interpretation, and also reporting. And it really, I think, is an example of the importance and what we can learn from each other using the heart team concept. So what we did was we just reviewed the definitions of pulmonary stenosis and insufficiency, and we also reviewed the indications for pulmonary valve replacement from the catheterization guidelines, the GIVA opinion paper in 2013, and then the ACHD guidelines from the American College of Cardiology, the European Society, and also the Canadian Society. And the thing that's interesting is that the recommendations do vary by guideline, and that there really isn't any guideline specific to pediatric patients. And we really take a lot of the guidelines from adults and extrapolate them to pediatric patients, which we don't know if that's the right thing to do or not, but that's the information we have. And then this is just an example of one of those tables looking at the indications for intervention. And then we went through recommendations for image acquisition. And a lot of this is for adult cardiology people who don't do a lot of congenital heart disease in terms of how to sort of image for the right ventricle. And so biventricular opacification is really important. And so I think you have to have a contrast injection that's going to opacify both the right and the left heart. When you look at some of the vendor case reports and indications how to do it, they say to really optimize the pulmonary artery. But I think it's best to have the pulmonary artery and the aorta both opacified, so you can get really great pictures of the coronary arteries and the relationship to the RVOT. The scan range, depending on what scanner you've got, should be optimized to visualize the RVOT and the branch pulmonary arteries. You can get accurate volume estimations as well if you have a dual source scanner, but that hasn't been validated yet on single source scanners. And then the radiation dose optimization is really important. And so you really want to minimize the radiation and individualize that to the patient. And so you can do a very narrow acquisition window and get very low dose scans, particularly on pediatric patients where you don't need detailed coronaries. And so this is just an example of what we're talking about. So when you think about anatomic imaging, a lot of times a CT scanner can give you just like one single snapshot. And what you're doing in that case is having an acquisition window that's a single cardiac phase. And what we recommend for the right ventricular outflow tract, particularly for the native RVOT, is to do functional or cine imaging. And in that case, you do a very narrow, fully radiated window, but you give 20% of radiation during the rest of the cardiac cycle. And you can actually get a cine functional data set from that. And so this is just kind of looking at the dynamism of the right ventricular outflow tract. And so I became interested in this because a lot of times people would say that, the cross-sectional imaging really doesn't help us because the measurements don't match. And I think that what we were doing is that in the past, when you're getting just a single phase, the cardiac cycle, you may or may not be where you need to be for what you need for valve implant. And so the way I think about the RVOT is longitudinal shortening. And an example of that is in figure 2. And it really is the variation in the length of the RVOT based on the cardiac cycle. And so what you want to do is have the longest dimension, because that's really going to be what is going to accommodate the longer valves, particularly the Altera and, the Harmony in those ones that have longer lengths. I think that's a better way to look at that. And you can see that the variation is, anywhere from like 1.8 centimeters to 4 centimeters in a single patient. And so that really is an illustration of why you need to get systole and diastole. And then on the bottom, I like to think of it as pulsatility. And so what you see on the bottom right is actually the same patient in systole and diastole. And you can see the difference in the major and minor dimension. And you can also see the difference in the average diameters. And I think the average diameter by far is a better way to look at it. And it probably matches much better the valve that you're going to pick for percutaneous valve placement. The adults, you can do area as well, but that's more common in TAVR than it is sort of in the congenital space. And so I think it's important to really get a functional scan, look at the maximal dimension for the linear dimension, and also look at the maximal dimension in terms of the right ventricular outflow tract to see if that valve is going to sit nicely once you put it in there. And so I think that for the reporting recommendations, I think it should be a nice standardized approach, which you can see there on the top right is sort of like the distal RVOT, which is better for the self-expanding valves, the annulus, which is better for some of the, bioprosthetic valves, and then the main PA, and then also the distal RVOT to the bridge of the bifurcation is really important if you're going to do a valve where you have a self-expanding valve that may extend into the branch pulmonary arteries. And so you know if you have room to do that without occluding the pulmonary artery. And in terms of a standardized approach, it's also really important to look at the variability of the right ventricular outflow tract and really have a detailed and patient-specific landing zone that matches the patient's anatomy. And these are just examples, a lot of pictures I know, but you can see on the top left, you can see an example of endocarditis. You can see valve leaflet calcification. You can see hypotonia leaflet thickening with restricted leaflet motion. And I think the reason that's important is that some of these patients might be able to be medically treated before they get a transcatheter valve. And then the other pictures on here are really showing the relationship of the coronary arteries to the right ventricular outflow tract. And I think that when you're looking at low versus high risk patients, a coronary anomaly is important. If the coronary courses between the aorta and the pulmonary artery, that's very important. If it comes off high in the aorta and has to go below the pulmonary valve, I think that's important. And I also think the location of where your landing zone is. So there's some patients where the proximal RVOT is widely patent and would be great, but like image B on the bottom left, you can see that the conduit is stenosed distally. And so I think you have to look at where is the landing zone for this patient and where is a coronary artery to make a very individualized assessment of coronary compromise. So in summary, I think that imaging can guide surgical and percutaneous interventions in the native RVOT, conduits, and bioprosthetic valves in congenital heart disease patients. I think patients who are not candidates can be excluded. So when you have an RVOT that's 4.5 or 5 centimeters, that patient's not going to be able to have a percutaneous option. I think it's also true when they're very small RVOTs that you wouldn't get a good result from. And I think that the landing zone and the valve sizing, we should be able to give you an idea before you go in there where your landing zone is going to be, what size valve you're going to be, and also the cath angles. You can actually get that from all of these software platforms. You can line out the RVOT exactly how you want to see it in the cath lab and give you the cath angle for that. And I think that this is an example of close collaboration between imagers and interventionalists that really optimizes care for our patients.
Well, thank you for that summary, Dr. Han. I have to say this, we know that there are a lot of these papers published for the TAVR side of things with the adult interventionists. So this is a much needed paper, and I congratulate you and your co-authors on this Herculean effort. Since this is about a collaboration between the surgeons, the radiologists, and the interventionists, I just have a side question before I open up for discussion with the panelists, and that is, when you guys were putting this together, were there any important controversies to disclose, mostly between the surgeons and the interventions as far as whether something should go to surgery versus the transcatheter pathway. I mean, I can just picture the big egos involved can lead to a lot of disagreements. Anything along those lines when you guys put this together?
No, not really. The biggest controversy came about whether to include the GIVA paper from 2013, because there's so much guidance for what to do in the adult population. There's very little in the pediatric population. But I think the surgeons and the interventionalists that we chose were actually really wonderful and collaborative to work with. And so there wasn't a lot of controversy, believe it or not.
Very good. So Matt and Shabana, do you guys have any comments about the paper or any questions to throw out?
Sure. First, Kelly, congratulations to you and your co-authors, and Frank, thank you and JSCAI for putting this together. This is a great forum. I think I have a comment first, and that is that you really nailed it here. Like, you really drilled in on the central issue that we're facing now in congenital interventions when it comes to pulmonary valve replacement, and that is the dynamic nature of the RVOT. And I think what our adult colleagues who are doing TAVR all the time are realizing is that implanting in the pulmonary outflow tract it's a much different animal than implanting into a calcific fixed aortic annulus. And so the dynamic nature, you really beautifully highlighted that, especially in some of the figures in your paper. They're really well done. So congratulations again on that. So a question for you as an imager, as doctors who are following children and young adults, the primary screening tool in the tetralogy flow population, for example, has been MRI through the years. Like Frank and I have grown up over the last 20 years as MRI has matured as the tool to really gauge ventricular health and help us make some objective decisions about the timing for pulmonary valve replacement. And, at CT scanning, as the newer technologies for pulmonary valve replacement have come out, has sort of moved ahead of MRI in terms of our planning. And my question for you is the reason that CT is the difference between CT and MRI. CT gives you better anatomical information. MRI gives you more functional information without the risk of radiation. So that's a long statement preamble, but when you talk about gated CT scans, what's on the horizon in terms of making these gated CT scans low radiation? Like, do you have any insight into photon counting scanners, and is this going to be reality? And second question is, do you see CT scans becoming sort of the screening, sort of tracking modality moving forward as a replacement for MRI?
So I think it's an interesting question. And I think when the scanners first came out, you gave radiation through the entire cardiac cycle and the doses were very high. And then as we've gotten to where you can just target it to a very specific point of the cardiac cycle and do very low dose through the rest, we published, 4 institutions with almost 1,500 cardiac CTs. And for a functional CT, the average radiation dose was about 2 millisieverts. And so when you look at the original papers that estimated cancer risk from pediatric patients, it was 30 to 50 millisieverts. And when you look at the variation in CT scans, it's anywhere from 0.2 to 60 millisieverts per scan, depending on who does it. And so I think that the importance is that you have a scanner with the best temporal resolution if possible, and you also dose reduce. And so when you look at the scanners out of the box, they are recommending the radiation you would need to get a detailed look at an adult coronary artery. And we're looking at big structures, and so we dial the doses way down over what is actually recommended. And I think it's really important to be at the scanner and know which patient you're looking at. And so typically, there's also 2 different papers that estimated cancer risk from radiation. They said less than 5 millisieverts was no risk or considered the control group. And I think that most of these scans now are done at less than 5 millisieverts. And so I think
let me just follow up that. How about cumulative dose over a lifetime? Because I'm thinking not just for procedural planning, but for following these patients and over time. Do you see a time that CT is going to replace or supplant MRI as your sort of patient tracking tool?
Well, so I think that it's very interesting because you look at comprehensive diagnostic risk. Gadolinium has got an FDA safety alert. It accumulates in brain and bone. You're not supposed to use it repeatedly in kids. And anesthesia also has a risk of neurodevelopment adverse events, and there's also the procedural risk of an adverse event. So when you're looking at a tiny baby, you can get a CT scan for a radiation dose almost similar to a chest X-ray, or you can put the patient under MRI, which includes anesthesia and usually gadolinium. And so I feel what you're doing is you're sort of balancing the risks of the patient. And I think that if you do really low dose CT, I think that it can be a nice tool, but I also think you have to be very careful of radiation. And in my mind, you should do MRI, and then when you're going to do the procedure, then do the CT. And so kind of use, have your toolbox, have everything in it, so you can use a targeted approach for what's best for the patient. In terms of our patients that have, pacemakers and stents, and a lot of these patients have a ton of metallic artifact, and the photon counting scanners are going to be phenomenal for that, and the radiation doses will be even lower than we currently have. And there's also a couple of studies looking at volumetric analysis with CT versus MRI, and they're fairly equivalent. And so I think that if you have a patient that's a pacemaker, a stent, you need to look at calcification and everything else. Just do a single CT that gets the volumes and the PAs rather than doing MRI and CT. And so I think you got to look at like the comprehensive cumulative risk and not doing redundant studies either. And so I think it's a complicated question.
You're not going to make any friends with the MRI people, Kelly.
I actually do
you really?
I am an MRI person.
Are you a conflict with yourself?
Too, There has been this sort of like siloed approach, and I feel like the best thing is to have all of us having great access to everything, and you can look at the patient and say, what do I need for this patient, and pick some modality. So yeah. That
was a great answer.
Yeah. Dr. Han, I have a corollary to that. First of all, congratulations on the publication, and to JSCAI as well. But the corollary that I have is a question I get asked for planning purposes. Will MRI ever replace CT for procedural planning? Will we be able to get the dimensional details that we need to place a pulmonary valve without getting a CT?
I think that means when you look at a whole heart sequence, which can be just absolutely beautiful right now, you're getting it in a single phase of the cardiac cycle. And so you're then stuck with, you have the static image again. And so the things you could do is maybe do like a cine image across the RVOT and try to get a sense of the pulsatility and how that is. But the other thing is ferumoxytol. I don't think I'm saying that correctly, but that's actually an intravascular contrast agent that stays in the vasculature. And so I think when you do what we call 4D MRI, where you're getting MRI in function, it might be that at that point you could, not do radiation, but then you're also giving a contrast agent. And so I think it's always going to be a balancing of the risks and benefits. And I do think ferumoxytol, where you can do an MRI in motion, very similar to the CT in motion, I think that's a place where MRI may be able to give similar information. But you're still going to have all the metallic artifact, and you also have a lot of flow artifact. And so when you have pulmonary insufficiency and you have a lot of dephasing and that kind of stuff, you sometimes can't do that. But some of the newer contrast agents that are intravascular and kind of stay around in the circulation, those might be ones that could give you something similar to a CT scan.
The next 5 years, MRI replacing CT for device planning from what you have seen so far?
I don't know. They're both the diagnostic capabilities of both modalities are increasing exponentially, and the risk is decreasing. And so I feel like when you're starting to talk about, for babies, a DLP of 1, it seriously is like a chest X-ray. And so I do think that MRI still needs sedation, and is always going to be a balance of what are the comprehensive risks for that patient. And I think that hopefully we'll just keep advancing both modalities so that you can use the best one based on indication and patient.
Yeah, one of the anatomic features that heightens my anxieties is when I see calcium on a conduit, because I cannot ever predict which ones will cause an uncontained dissection. So I know that the CT can be very helpful to determine whether this is circumferential or the locations of it. But can you think of how, if CT can help us to at least predict which ones may have a higher risk of dissection when we're trying to open up a valve, a conduit that's a little larger than what it should be, et cetera, et cetera. Anything that you can, any tips you can give us using CT to assist that when you see these calcium calcifications?
I think, like you said, it's the extent of calcification and whether or not it's circumferential, and you're going to actually have to crack that in order to get the valve bigger. And so I think that when you look at the RVOT and short axis, and you're kind of marching down that RVOT, When you see the circumferential calcification along the length of the conduit, those are the ones that worry me the most. Sometimes you'll have extensive calcification. It'll just be in one part of the conduit. And I think that when it's circumferential and extensive, those are the ones where you really have to worry that you're going to crack that and cause a dissection when you are aggressive with pre-stenting and ballooning.
Dr. Han, you showed some great images of coronary proximity, but one of the challenges we have is if the surgeons left 4 previous conduits behind, then although the distance between the current conduit and the coronary appears far, it might still cause compression. Are there any features on CT or MRI that might clue you in on anything other than distance that might impact the coronary compression or proximity?
Yeah, so I think there's 2 things that I feel like, and it hasn't been studied, but it's my opinion, and we did put it in the paper. So the one is when the coronary origin is between the aorta and the pulmonary artery on a short axis image. I think that's one. I think the other thing that's really important is the height of the coronary related to the right ventricular outflow tract conduit. So when you have a coronary that arises high and the conduit is, and actually has to drape below the conduit, I think that is another risk factor. And so if you have a coronary anomaly, if the coronary arises between the aorta and the pulmonary proposed conduit or bioprosthetic valve placement, then also I think the high origins where it has to actually drape underneath the conduit is another risk factor. We had an example of that we put in the paper where the coronary came, and I like to think about the conduit as having kind of like a mid-zone. And I feel like if your coronary rises above the mid-zone of the conduit, there's higher risk of compression when you start to balloon and expand and intervene on that. Where if it's going below the conduit and it's not having to be draped across there, I think that's safer.
I agree. There are definitely anatomies that you can look at by CT and say, oh yeah, I'm not even going to mess around with that coronary the way that it's draped. I think what Shabana is getting at is we've both seen some very, and Frank too, we've seen some very benign looking coronary arteries with, when you go in and do some test inflations on a conduit or on an outflow tract, the coronary seems remote, but the tissue between the coronary and where you're intervening is non-compressible, and it just transmits the force. And actually, your coronary is remote, but you actually compress it even though you're not near it. So I think, that's the holy grail. Can we predict, is there something by tomographic imaging, either MR or CT, that can give us the green light so that we don't have to go about compression testing and all these other things that we do that really can prolong the procedures that we do? And I think the answer is no, but that's something to consider for future work. Is there something we can do to define the space in between and whether or not we can predict that that's going to compress or just kind of move into the coronary?
I do think some of the virtual valve placement might be interesting for that, because I think that you can actually see where the valve or valve complex is going to be related to the coronaries and how that might move. And so I think all of the vendors are starting to move towards having little STL files. You can actually put the virtual valves into the person's anatomy before you go to the cath lab. I think that that can be helpful as well.
Sure.
Along the lines of coronary compression, you mentioned in the paper that you can minimize radiation if you don't have to assess the coronaries. Now, granted, CT can give you really good anatomic assessment of the coronaries. It doesn't assess the compression. And since we all do coronary angiograms for compression anyways, at least for the conduits and the valves, is there a need for actually assessing the coronaries outside of looking at the course? And I guess I'm just thinking along the lines of radiation minimization and so forth.
So I think that when you do the functional scans where you have a very narrow acquisition window and only 20% during the rest of the cardiac cycle, you can actually watch the dynamism between the RVOT conduit, bioprosthetic valve, and the coronary. And that's where we actually would predict that sometimes. So when I was working with Dr. Garcia, who we did this together, we actually, every single patient that we sent to the cath lab got a valve. And there was 2 patients that we thought were high risk for coronary compression based on the dynamism. And so you could watch the conduit pulling the coronary inferior actually in motion. And so there's 2 patients that said, I want to go and try it just in case you could do it within the cath lab. But I think that the dynamism is important for the RVOT, but the dynamism is also very important for assessing the coronary relationship to the RVOT. And so I think that when you watch those in motion, and then in the paper we talked about, coronary definition, I think that part of it is if you're looking at detailed coronary, looking for coronary stenosis and lesions in adults, but for all of these studies, you should have the coronary definition for in relation to the RVOT.
So we only have a few minutes left. Since both Matt and Shabana are high volume operators, can you guys give the audience a couple of tips on how this paper and the CT role in transcatheter pulmonary valve replacement may be helpful to the audience? I'll start with Matt.
Sure, I'll go first. First, think about the indication why you're coming to the cath lab. So if you're coming in to deal with a stenotic lesion, you're going to make it bigger. I would say, as beautiful as your images are on CT scan, you have to check your coronaries. You don't want that to be a problem. So do compression testing, even if the CT scan seems reasonable, because Frank and Shabana will tell you that we have discovered, just by doing some test inflation, you don't want to have a coronary complication. So read this paper, look at these beautiful pictures, but always test your coronaries. And that's if you're dealing with stenotic lesions in particular. And then, we're in the new era of all these self-expanding devices. And so I think what Kelly in her paper and the authors have really shown is how dynamic the RV outflow tract is. The 2 devices that are approved in the States are the Harmony and the Altera systems, and all their screening is based on these CT scans. So my advice to everybody is to really understand that what these reports are intended to convey to you, that you get from the industry, is how dynamic the outflow tract is. And once you start to understand how these CT scans are acquired and the dynamic nature of the outflow tract, you can really begin to interpret these reports and understand where you want to land them. So I think this is a good paper to have, so that you understand how these scans are obtained. And I think it really informs the report that you're going to get from both Edwards and from Medtronic about your self-expanding device. Shabana?
Actually, I'm going to pick off right what you said, Matt. I think those are excellent points. And in terms of the native RVOT, the first thing I want to remind people is to look at more than the perimeter plot or the fit analysis that's sent to you. So the perimeter plot doesn't take angulation. So look at the raw data itself, understand the angulation of the RVOT, and more than that, these are average measurements. So there is going to be some leeway, especially when you go to the borderline cases. So take time to sit down with these reports and the CT raw data before you go ahead and try to put a device in. So I think that's key. And then building the relationship with your imaging partner and spending time with them and understanding things, so you can sit down and have a reliable partner to evaluate these complex RVOTs. As interventionalists, we are used to 2D angiography, and then understanding 3 structures 3-dimensionally is something we're just starting to do. So sitting down with somebody who does that for a living and taking their understanding and using it to your patients will be to our benefit.
Well, thank you very much. I think our time is up, and I really appreciate Matt and Shabana and Kelly for joining us on this edition of Conversations in Interventional Cardiology. Thank you very much.
Thank you.
Thanks,
All right.
See you guys.
Bye-bye.
Thank you.